Hello, my name is Keri Gargiullo, and this is my presentation on anthrax, tuberculosis, and atypical pneumonia. The origins of anthrax are estimated to go back as far as 700 BC in Egypt and Mesopotamia. Rome and Greece are also thought to have experienced the disease, and some consider anthrax to have played a part in Rome's downfall. The first clinical descriptions of cutaneous anthrax were given by Maret in 1752 and Fournier in 1769. In 1877, Robert Koch injected animals with a pure culture of Bacillus anthracis and was able to observe how it caused disease. From this, he was also able to determine the life cycle of the anthrax bacteria and was able to demonstrate a causal relationship between a specific microorganism and a disease, which is now known as Koch's postulates. The creation of the first vaccine for anthrax was in 1881 by Louis Pasteur. Anthrax is a zoonotic disease caused by a gram-positive, rod-shaped, spore-forming bacterium known as Bacillus anthracis. It can be found in contaminated vegetation, water, or soil, and commonly affects domestic and wild animals throughout the world, like camels, sheep, cattle, goats, antelope, and deer. These act as reservoirs for the disease, and humans can become incidental hosts. The method of transmission of this disease occurs through spores, which can be inhaled, ingested through contaminated food or water, through scrapes or cuts in the skin where the spores are able to enter the body cutaneously, or a more recently discovered pathway of infection, which is injection of contaminated heroin. Anthrax is not spread from human to human or animal to animal. The B. anthracis life cycle comprises two forms, a dividing vegetative form and dormant spores, which become activated when they come into contact with oxygen and become active growing cells. Once the spores have germinated in the body of the infected host, the bacteria will begin to produce anthrax toxin, which is what subsequently causes illness. Anthrax toxin produces two essential virulence factors called lethal factor and edema factor, and they act during two distinct phases of anthrax infection. During the prodromal phase, which is the asymptomatic phase of the infection, these toxins act on the macrophages, dendritic cells, and neutrophils of the immune system that will engulf and transport the bacterial spores from the site of infection to the lymph nodes, altering their migratory behavior, inducing their cell death, and dysregulating their production of immune cytokines. During the fulminant phase, where the disease is rapidly progressing, an important effect of lethal toxin and edema toxin is to breach the vascular barrier between the bloodstream and tissues, which leads to a variety of systemic effects that contribute to fatal outcomes, even when the proliferation of bacteria is curtailed by antibiotics. During the final phase of infection, the toxins cause an increase in vascular permeability and a decrease in the function of target organs, including the spleen, heart, kidney, adrenal gland, and brain. The incubation period of anthrax is usually 1 to 7 days, but incubation periods last as long as 17 days have been reported. Cutaneous anthrax begins with a raised area on the skin that itches and resembles an insect bite, and usually occurs on exposed areas on the hands, face, or neck. Within 1 to 2 days, this area will develop an ulcer surrounded by small blisters containing fluid. It will then develop a characteristic black crusty spot, and within a few weeks it will begin to loosen and fall off. Anthrax was actually given its name by Hippocrates because of the black skin lesions that were observed. In Greek, the word anthrax means coal. Injection anthrax symptoms are similar to those of cutaneous anthrax. However, injection anthrax can spread throughout the body much faster and be harder to recognize and treat than cutaneous anthrax. Gastrointestinal anthrax can present as either intestinal or throat and pharynx disease. These symptoms include fever, nausea, abdominal pain, vomiting, and anorexia. Some more serious symptoms that can occur as the disease progresses are vomiting of blood, bloody diarrhea, toxemia, dysphagia, cyanosis, edema in the tissues of the throat, and swelling of the lymph nodes. Inhalational anthrax begins with 1 to 3 days of fatigue, low-grade fever, and a dry cough. These symptoms, which are similar to those of a mild upper respiratory tract infection, may be accompanied by an ache of feeling of heaviness in the chest and the area just below the chest. Following this, there will be a period of more intense illness characterized by high fever, elevation of the pulse and respiratory rate, heavy perspiration, and difficult or labored breathing. Anthrax meningitis may develop from the spread of any form of anthrax, or it may occur alone. Half of all reported cases are sequelae of cutaneous anthrax. It could be suspected that an anthrax patient may have meningitis if they have a severe headache, altered mental state like confusion, meningeal signs, or neurologic deficits of any kind. Since cases of anthrax are very rare and the symptoms are similar to those of other common illnesses, patient history is very important when diagnosing this disease, as the method of transmission is a key component to understanding that the symptoms the patient experiencing could be related to anthrax. Once it's suspected that a patient may have inhalation anthrax, chest x-rays or CT scans can help confirm this if the patient has a mediastinal widening or pleural effusion. Other than this, the only ways to confirm an anthrax diagnosis are by measuring antibodies or toxin in the blood or testing directly for Bacillus anthracis in a blood sample, skin lesion swab, spinal fluid, or respiratory secretions. Antibiotics are the main source of treatment for anthrax, and it's extremely important that individuals who have been exposed to the pathogen begin treatment immediately, before symptoms begin. If symptoms begin before starting an antibiotic, there is a much larger likelihood that treatment will be unsuccessful. Penicillin is used to treat all forms of anthrax, and the addition of ciprofloxacin and doxycycline have also been approved to treat inhalation anthrax. The only effective pre-exposure prevention against anthrax is vaccination. This vaccination is not available to the general public, and it's only available to individuals between the ages of 18 to 65, and they would need to be considered a high risk of exposure. Anthrax is the most common in agricultural regions in Central and South America, Sub-Saharan Africa, Central and Southwestern Asia, and Southern and Eastern Europe. Although outbreaks still occur in livestock and wild herbivores in the United States, Canada, and Western Europe, human anthrax in these areas is very rare. Between 95 to 99% of all anthrax cases reported in humans is cutaneous anthrax. The mortality rates from anthrax vary depending on the exposure and are approximately 20% for cutaneous anthrax without antibiotics and 25 to 75% for gastrointestinal anthrax. Inhalation anthrax has a fatality rate that is 80% or higher. Another deadly threat of anthrax is the use of Bacillus anthracis spores as an act of bioterrorism. In 2001, powdered anthrax spores were deliberately put into letters that were mailed throughout the U.S. postal system. 22 people, including 12 mail handlers, got anthrax, and 5 of these 22 people died. Although Johann Schlonen coined the name tuberculosis in 1834, it is estimated that Mycobacterium tuberculosis, or MTB, may have been around for as long as 3 million years. In ancient Greece, TB was called phthisis, it was called tabes in ancient Rome, and shashpeth in ancient Hebrew. By the 1700s, TB was called the White Plague due to the paleness of patients, and even after it had gotten its official name in the 1800s, it was commonly called consumption and captain of all these men of death. Today, TB is known as an airborne pathogen, and it is spread when a person with the disease coughs, speaks, or sings, but this was not always the case. In the early 1800s, TB outbreaks would cause vampire panics throughout New England. It was believed that when the first member of a household died of TB, they would come back as a vampire to infect the rest of the family. To stop the vampires, townspeople would dig up the suspected vampire grave and perform a ritual. MTB is a fairly large, non-motile, rod-shaped bacterium. It's an obligate aerobe, which makes this bacterium a huge fan of residing in the well-aerated upper lobes of the lungs. MTB is not a gram-positive or gram-negative bacterium, but like its species Mycobacterium, this bacteria is an acid-fast bacteria due to containing peptidoglycan and mycolic acid in their cell wall, which makes them impermeable to certain dyes and stains, and also contributes to its resistance to antibiotics, which we will talk about later. TB is a disease that is only spread through respiratory droplets of humans, which are spread through coughing, speaking, and singing of a patient who is actively experiencing symptoms of TB. The droplet nuclei are so small that they tend to remain airborne for an extended period of time. After a droplet of nuclei are inhaled, the bacteria are nonspecifically taken up by alveolar macrophages. At this point of infection, macrophages are not activated and are unable to destroy the organism. This is considered latent TB, as the host will not be showing any signs or symptoms and is not contagious. When the droplet nuclei are inhaled, larger droplet nuclei may become lodged in the nose or throat, and from here, infection is unlikely to develop. When smaller droplet nuclei reach the alveoli of the lungs, that is where the infection begins. Within 7 to 21 days after initial infection, MTB multiplies virtually unrestricted within macrophages until the macrophages burst. Other macrophages begin to escape from peripheral blood and begin to phagocytose MTB, but they are also unactivated and are still unable to destroy the bacteria. At this stage, T cells begin to recognize the MTB antigen and release cytokines, including gamma interferon. This causes the activation of macrophages, which means that they are finally capable of destroying MTB. At this point, the host is tuberculin positive. They are contagious and is the result of a cell-mediated immune response. This is generally when the replication of MTB will slow down due to the activation of macrophages to control the infection. However, some remain unactivated or poorly activated, and MTB uses these to replicate, allowing more tubercle growth. At least 9 out of 10 patients infected with MTB will stop at this phase of infection and do not develop symptoms or physical signs of the disease. When a growing tubercle invades a bronchus, the infection can spread to other parts of the lungs. The tubercle may also invade an artery or other blood supply line, which may result in extrapulmonary or miliary tuberculosis, which creates a metastasizing tubercules that are about the same size as a millet seed, a grain commonly grown in Africa. Miliary tuberculosis can then cause secondary lesions, which can target almost any other location of the body, but usually target the genitourinary system, bones, joints, lymph nodes, and peritoneum. In cases of TB where the host does not die from their initial TB infection, many of the metastatic foci in the lungs will calcify, and some of them will hold on to viable organisms. These foci are referred to as Simon foci, which are visible upon chest X-ray and are often the site of disease reactivation around 12 to 24 months after the initial infection. In an individual with latent or inactive TB, they will not be experiencing any symptoms, but if given a tuberculin skin test, it will detect MTB in the body. This still indicates a TB infection, but the bacteria are not yet causing harm to the host. TB can be much more dangerous for individuals living with the HIV virus. These patients are much more likely to become sick with TB disease. Symptoms of active TB disease include a cough that lasts more than 3 weeks, loss of appetite and unintentional weight loss, fever, chills, and night sweats. More advanced symptoms such as coughing up blood or mucus is a sign of TB in the lungs, and bone pain can indicate that the bacteria have invaded the bones. The 2 kinds of tests that are used to detect TB bacteria in the body are a TB skin test, which is commonly known as a PPD, or a TB blood test, which is also known as quantiferon gold. Both of these methods of testing will indicate that TB bacteria are in the body, but will not indicate whether the patient has a latent TB infection or it has progressed to TB disease. Since it's common for a TB skin test to produce either a false negative or a false positive diagnosis, it's important to undergo further testing to determine if the patient has active TB disease, especially if they're experiencing symptoms. Further testing to confirm TB disease include examination of medical history, a physical examination, chest x-ray, or culturing of sputum to detect the acid-fast bacilli. In confirmed TB cases, the early identification of drug-resistant strains of MTB is crucial to successful treatment. Since TB can be either a latent infection or progress to TB disease, these two TB-related conditions follow different treatment regimens. Regardless of if the patient is diagnosed with TB, latent TB, or TB disease, it is almost always treated with what is referred to as an antimicrobial cocktail. For latent TB, approved medications include isoniazid, rifapentine, and rifampin. These medications are given throughout a 3 to 4 month period, which allows a specific regimen that is recommended for each individual by their care provider. Although patients with latent TB do not show symptoms and are not contagious, there is a chance that they could develop TB disease at some point, and those chances are much higher for individuals with HIV, diabetes, or other conditions that affect the immune system. For that reason, it's strongly recommended to proceed with a treatment regimen for latent TB to help prevent the future onset of TB disease. For TB disease, there are 10 drugs currently approved by the FDA for treating TB, but the first-line anti-TB agents that form the core treatment regimens are isoniazid, rifampin, ethambutol, and pyrazinamide. These medications are generally given throughout a 6 to 9 month period, which involves an intensive phase of 2 months, followed by a continuation phase of either 4 to 7 months, depending on the recommendation of the patient's care provider. Although a vaccine for TB exists, it's not widely used in the U.S., but it's given to infants and small children in other countries where TB is more common. This vaccine does not always protect people from getting the disease. TB affects mostly adults in their most productive years, but all age groups are at risk. Other risk factors include immune disorders, undernutrition, alcohol use disorder, and tobacco smoking. HIV is the number one risk factor for MTB infection. 10% of all HIV-positive individuals harbor MTB, which is 400 times the rate associated with the general public. In 2019, there were 8,916 reported cases of tuberculosis in the United States. The U.S. has one of the lowest TB case rates in the world, and the 2019 case count represents the lowest number of TB cases on record. But it is still estimated that up to 13 million people in the U.S. are living with a latent TB infection. Worldwide, 1.4 million people died from TB in 2019. 30 countries accounted for 87% of new TB cases in 2019. 8 countries, which account for 2/3 of the new cases, are India in first place, followed by Indonesia, China, the Philippines, Pakistan, Nigeria, Bangladesh, and South Africa. Because of improved diagnosis and treatment, an estimated 60 million lives were saved between 2000 and 2019. Atypical, or walking pneumonia, was given its name around the 1930s when scientists began reporting pneumonias that were atypical compared to characteristics seen in typical pneumonias. Patients tended to not be as sick, have symptoms for a longer period of time, and they would not respond to some antibiotics that were used to treat typical pneumonia. Typical pneumonia is commonly caused by a bacterium called Streptococcus pneumoniae. However, through the discovery of atypical pneumonia, researchers have found that there are 4 different bacteria which cause this illness, and they are harder to detect through standard bacterial methods. These bacteria are Chlamydia pneumoniae, Chlamydia psittaci, Legionella pneumophila, and Mycoplasma pneumoniae. Although these are all considered atypical pneumonia, they are certainly not uncommon. Chlamydia pneumoniae is a gram-negative aerobic intracellular bacterial pathogen that commonly causes atypical pneumonia. C. pneumoniae is transmitted through direct contact with respiratory droplets of a person who is infected. This can include direct inhalation of the droplets or touching the mouth or eyes after touching a fomite such as a door handle that contained respiratory droplets from an infected person. The incubation period for C. pneumoniae is usually between 3 to 4 weeks after first exposure. Symptoms can also continue for several weeks after they start. Although C. pneumoniae commonly infects people for the first time when they are school-age children or young adults, those at an increased risk include those who live or work in crowded settings where outbreaks most commonly occur, such as schools, residence halls, nursing homes, hospitals, and prisons. Older adults are at an increased risk for severe disease caused by C. pneumoniae infection. Chlamydia psittaci is a gram-negative aerobic spherical bacterium that most commonly infects birds, and it is known to cause mild illness in humans called psittacosis and can also cause atypical pneumonia. This bacterium generally infects people who are exposed to birds who carry this pathogen. Infected birds do not always show signs of disease or seem sick, but they are capable of infecting humans regardless. Birds shed the bacteria in their droppings and respiratory secretions. When the droppings and secretions dry, small dust particles carry the bacteria in the air, and the most common portal of entry in human hosts is through inhalation of this bacteria containing dust. Less commonly, birds infect people through bites and beak-to-mouth contact. In general, people do not spread psittacosis to other people, but it is possible in rare cases. There's also no evidence that the bacteria spreads by preparing or eating chicken or turkey meat. People infected with this pathogen generally begin developing signs and symptoms within 5 to 14 days of exposure. People of all ages are at risk of being infected by this pathogen, but those most at risk include bird owners, aviary and pet shop employees, poultry workers, and veterinarians. Legionella pneumophila is a gram-negative aerobic intracellular pathogen, and it's the causative agent of Legionnaire's disease, a severe form of atypical pneumonia, and Pontiac fever, a milder influenza-like illness. This bacterium is naturally found in freshwater environments like lakes and streams. It usually becomes a health concern when it grows and spreads in human-made water systems like shower heads and sink faucets, hot water tanks and heaters, and large plumbing systems. When water is released from these reservoirs, which contain L. pneumophila, it produces droplets small enough for people to breathe in. It is also possible to become infected by aspirating drinking water containing the pathogen. Symptoms of Legionnaire's disease usually begins 2 to 10 days after being exposed to the bacteria, but it can take up to 2 weeks for symptoms to appear. It's important to note that most healthy people exposed to this pathogen do not get sick. Those at a highest risk of getting sick are people 50 years or older, current or former smokers, people with COPD or emphysema, people with weak immune system or who take drugs that weaken the immune system, people with cancer, and people with underlying illnesses such as diabetes, kidney failure, or liver failure. Mycoplasma pneumoniae is a gram-negative aerobic extracellular pathogen, and it most commonly causes atypical pneumonia. This pathogen is transmitted from person to person through the inhalation of respiratory droplets from an infected person. Most commonly, people who live with someone who is infected with M. pneumoniae are more likely to become infected due to the prolonged exposure to that individual. Similar to C. pneumoniae, M. pneumoniae is most common in young adults and school-aged children, but can affect anyone. People living and working in crowded settings like schools, residence halls, nursing homes, and hospitals are also at an increased risk. Individuals recovering from a respiratory illness or those with a weakened immune system are at an increased risk for more serious infections. Although atypical or walking pneumonia can be caused by a variety of different pathogens, symptoms usually present similarly among people who become infected and are usually mild. The most common symptoms are fatigue, sore throat, sneezing, headaches, chills, a persistent or worsening cough, chest pain, low-grade fever, and shortness of breath. In older adults with Legionella pneumonia, They may cough up bloody mucus or experience diarrhea. Children younger than 5 with an pneumonia infection may also experience watery eyes, wheezing, and vomiting. People with a suspected case of atypical pneumonia should have a complete medical evaluation. It may be hard for health providers to tell if a patient has pneumonia, bronchitis, or another respiratory infection based on signs and symptoms alone, so a chest x-ray is usually the best way to diagnose pneumonia. To distinguish between the causative agent of the pneumonia, medical history, demographics, and recent whereabouts can help health providers narrow it down. Other tests like sputum cultures, nose or throat swabs, blood cultures, or even urine analysis can determine the bacteria which cause the infection, although this is generally only done in severe cases. Most of the time, atypical pneumonia is relatively mild, and in these cases, it's strongly recommended to treat symptoms with over-the-counter medicine like ibuprofen or acetaminophen, drinking plenty of fluids, and getting a lot of rest. In more severe cases, providers will treat with antibiotics. Due to the atypical antibiotic-resistant nature of the bacterium that causes these infections, it's crucial for providers to identify the causative pathogen in order to appropriately treat patients. The most common antibiotics which are used to treat most of these infections are macrolides, tetracyclines, and fluoroquinolones. Some strains of pneumonia have become resistant to macrolides over the past decade due to the increased use of this antibiotic for various conditions. Because pneumonia also lacks a cell wall, they are inherently resistant to all beta-lactam antibiotics like penicillin and ampicillin. C. pneumoniae has also shown in vitro resistance to penicillin and ampicillin, and therefore are not recommended for treatment. There are currently no vaccines available for any of these infections, but they are 100% preventable if appropriate steps are taken. Atypical pneumonia is caused by pneumoniae, and C. pneumoniae is preventable. Washing hands with soap and water, practicing good hand hygiene, and staying away from people who appear to be coughing or sneezing are all helpful ways to protect yourself on a daily basis. To help prevent L. pneumophilia infection, ensuring that residents, building owners, and managers maintain building water systems in order to reduce the risk of bacteria growth and spread. To help prevent C. stichtati infection, it's important for bird owners to do their research before purchasing their pet and only buy pet birds from well-known and reputable pet stores. It's equally important to ensure that cages are kept clean, overcrowding birds is avoided, and birds that display signs or symptoms of disease are isolated and properly treated. There is currently no national reporting or surveillance system for C. pneumoniae or M. pneumoniae infections. However, the true number of people affected by these pathogens is unknown and it's likely underestimated. Since 1988, there has been a decline of reported C. stichtati infections. Since 2010, the CDC has typically received reports of less than 10 cases in the United States per year. The number of reported L. pneumophila infections has been on the rise since 2000. Health departments reported nearly 10,000 cases in the United States in 2018. Because these infections are likely underdiagnosed, this number may underestimate the true incidence. Thank you.